and you will see that I hope we were able to build a program that starts from the very basics. For some of you, this thing will appear a little bit obvious, and then growing to more complex things. My conflicts of interest, which are not really related to this course, although have to do with this topic, although have to do with mechanical ventilation. So just to start, I will speak about a situation where we are in the, let's say, most simple possible condition from a mechanical point of view, which is the total absence of a patient respiratory effort, either because of a neuromuscular blocking agent or for a patient condition. But in any case, you will have to think during my talk to a patient who is not spontaneously breathing, and so where the physician, through the ventilator, has full control over the respiratory pattern of the patient. So which are the modes, the controlled mechanical ventilation modes that we can use? Of course, the most, I would say, classical one, also from a historical perspective, is the volume-controlled ventilation. Unfortunately, this is something that sometimes we struggle with, especially with our younger colleagues, that the same ventilatory modes has different names on different brand of ventilators. So depending on which ventilator you will be working on, this ventilatory mode could be called CMV or IPPV, but basically more or less the principle, not more or less, the principle under which these ventilatory modes work is always the same. And then on the other side of the ocean is pressure control ventilation. So for example, pressure control, pressure assist control, BiPAP, bi-level ventilation, APRV. In the absence of patient breathing efforts, all these modes work exactly in the same way. And then we have ventilatory modes that are sometimes, that are in a sense a bridge between a volume control ventilation and the pressure control ventilation, which are so-called pressure regulated volume control ventilation. As we will see, our main target, the target we set in the ventilator, is a volume target, but then the ventilator will work as if it was in a pressure controlled mode, and we will see how this works. So in essence, we also have to keep in mind that the only physical parameter, the only physical entity which the ventilator can modulate is flow. This is something we should never forget. Everything that the ventilator, I must have said something really wrong. Everything we set on the ventilator, a pressure target, a tidal volume target, a flow target, everything is achieved by the ventilator delivering flow to the patient or letting a flow exhaled, getting out from the patient, letting the patient exhaling. So the basic principle of the ventilator is the presence of a compressed gas source. It can come from a compressor, from the wall, from a tank, from a turbine inside the ventilator. And then there is an inspiratory valve which, when is open, allows the flow to move from the ventilator inside the patient. And in this phase, the expiratory valve is normally closed. When the patient needs to exhale, the ventilator will close the inspiratory valve and will open the expiratory valve and let the patient exhale. So when we work with volume control ventilation, the setting, our target, our recipe, the recipe we give to the ventilator is a recipe that is targeting a given minute ventilation. So a given volume delivered to the patient every minute. okay? And of course, we can split this minute ventilation, say 6 liters per minute, into an infinite combinations of tidal volumes and respiratory rate. For example, we can use 12, a respiratory rate of 12 and the tidal volume of 500 ml, 6 liters per minute, or we can decide to go with a respiratory rate of 6 and the tidal volume of 1 liter, and the minute ventilation will be exactly the same. Now, the interesting part, I think, of mechanical ventilation comes from the monitoring which we can achieve while we are ventilating a patient. So monitoring as one aspect, which is of course safety. We do not want our patient to blow up. We do not want the lungs of our patient to become atelectatic. So there is one aspect which is safety. But then the most important and the most valuable aspect of monitoring is the fact that we can actually gather many informations on the status of the lung of a patient by ventilating and by reading the ventilator curves. So I always like to think to mechanical ventilation to a procedure which is at the same time therapeutic or supportive, if you wish, but also diagnostic. There is so much to learn on the respiratory mechanics of the patient and on the disease of the patient by looking at the parameters we measure on the mechanical ventilator. So think of your ventilator not just as a tool to ventilate the patient, but as a tool to monitor the patient and to make a diagnosis on the patient. And of course, the most important, or let's say the parameter which we have readily available on the ventilator screen is airway pressure, or pressure at the airway opening, okay? It is a synonym, if you wish. Airway pressure, pressure at the airway opening. And in a passive patient, the pressure at the airway opening is just the sum of two components. One is the resistive pressure, so the pressure that we need to spend, to the price we have to pay to push the flow through the airways. And then there is the elastic recoil pressure of the lung and of the chest wall, which is generated by the respiratory system after the volume is delivered. So why I am so into mechanical ventilation? Why did it become my passion? Because I am very, very lazy, okay? And with mechanical ventilation, it's ideal for lazy people because you have to learn just one thing, which is the equation of motion of the equation of motion of respiratory system. And once you've learned that, you're all set. So if you are very lazy, then mechanical ventilation is for you, because this equation is always valid. If the patient is spontaneously breathing, you just have to add the term of the P mass, of the pressure generated by the patient. But it's not the topic for my talk. So after we set our tidal volume, we will set a given IE ratio or a given inspiratory time, again depending on which ventilator we are working with, and the ventilator will calculate the flow which has to be delivered for the patient. So basically the area of this flow, has to be equal to the tidal volume. This will be 500 ml, for example, or we can deliver the same tidal volume in a shorter time with a higher flow. Now let us imagine that we have no patient connected to the end of the endotracheal tube. There is just the tube, the resistance, okay? What will you see on the airway pressure waveform? You will see something like this. You will see a pressure which has exactly the same shape of the flow, okay? There is no pressure when there is no flow. Then the ventilator pushes the flow through the resistance of the tube, and so we read the pressure, and then the flow goes back to zero, and the pressure goes back to zero. there is no flow, there is no resistive pressure, okay? Now we connect to the other side of the endotracheal tube the patient, the respiratory system of the patient, and here, to be very simplistic, it's just one big alveolus, okay? So our flow, as soon as is flowing into the patient, becomes a volume which is distending the alveoli. And the respiratory system reacts to this volume change. It wants to go back to the relaxation volume, and so there is a pressure which is generated inside the respiratory system due to the elastic recoil of the system. And as soon as the flow stops, the green component, the resistive component, immediately goes to zero, and the pressure that we read in the respiratory system will just be the elastic recoil pressure of the respiratory system. The green component is gone, no flow, no resistive pressure. There is just the elastic recoil pressure. And I will not go into details because the next talk is about monitoring, and Claude will explain everything into all of this into details. So basically, again, I don't want to talk too much about monitoring, but in volume control ventilation, when the mechanical properties of the respiratory system change, the pressure that we read on the screen changes. The pressure is the dependent variable, and the flow is the independent variable. When we move to pressure control ventilation, then the independent variable in the ventilator brain is the pressure. The ventilator wants airway pressure to achieve a given target that we set, okay? So we set a peak inspiratory pressure of 20 centimeters of water, and the ventilator will try to have the pressure reaching 20 centimeters of water. But the equation of motion is exactly the same. How does the ventilator change the pressure in the patient airway? By, again, delivering a flow. It is the only way by which the ventilator can change the pressure. If you take a ventilator and disconnect it from, let's say, from the balloon, from the test balloon it is connected to, if the ventilator is set on volume controlled mode, there will be just a small flow coming out from the ventilator. You will hear like the tidal volume which the ventilator is delivering. But if the ventilator is set on pressure control mode and you disconnect it, immediately there will be a huge flow coming out from the circuit. The ventilator will go because it is trying to get to the target inspiratory pressure. And of course, the ventilator is not able to change the pressure in this room, and so it will deliver as much flow as possible, but the airway pressure will not change. This is the working principle of pressure control ventilation. The ventilator says, okay, I need to reach a target of 20 centimeters of water, so it starts to deliver a flow. And so flow goes immediately to a given peak, and then this flow reaches the alveoli. It is transformed. It becomes a volume which is distending the alveoli. And so the gradient between the alveoli and the airway will become smaller. And so the flow will decrease and decrease and decrease. There is less pressure that the ventilator can spend in generating flow because more pressure is spent to keep the alveolus expanded. If the mechanical properties of the respiratory system change, airway pressure will not change because airway pressure is set by us. What will change is the effect, is the tidal volume. The result in this case, the dependent variable in this case is flow and volume. And so I think there's a frequent misunderstanding in regard to pressures during pressure control ventilation. So if I was to ask you how much is plateau pressure in this condition, this is pressure control ventilation. If I was to ask you how much is plateau pressure in this condition, we might be tempted to think that, oh, this is flat, this is plateau. No, this is not plateau, because there is still flow moving from the ventilator to the patient. So we have to set ourselves in a condition of zero flow so that we read the real plateau pressure. And again, Claude will go back to this. There is another important thing. If we change the inspiratory time during volume control ventilation, pressures will change because the flow will change. But if we change the inspiratory time and the respiratory rate during pressure control ventilation, this will affect tidal volume. Why is that? So we start from a tidal volume of 440 ml with an inspiratory time of 0.8 seconds. And as you see here, by the end of the inspiration, there is still flow moving from the ventilator to the patient. So if we increase the inspiratory time, we give more time to the ventilator to deliver flow and to reach an equilibrium between the airway and the alveoli, and so the tidal volume increases. And if we increase the inspiratory time further, the tidal volume keeps increasing and increasing a little bit more. But if we keep extending the inspiratory time, the tidal volume will start to decrease again. Why is that? Because we are not giving enough time for the patient to exhale. And so basically, the patient is trapping some gas. And the pressure gradient between the ventilator and the alveoli is getting smaller because there is still some gas in the alveoli. So the ventilator already finds a pressure when it is starting to deliver the flow. Just one word on APRV, airway pressure release ventilation. What is APRV? Again, I think this is something there is a little bit of confusion on. If we are speaking about a passive patient, okay, if the patient starts to breathe, then the difference between APRV and pressure control has also to do with synchrony, and we will see this during the next lessons. But let's think to a passive patient. The idea of APRV is a ventilation which has a very long inspiratory time and a very short expiratory time. So the patient is basically always kept at inspiration and then shortly drops to expiration here. However, not because we set the APRV mode on our ventilator, necessarily this principle is applied. As you see here, I can use the APRV as a traditional pressure control mode, or I can decide to use a traditional pressure control mode to perform a sort of APRV-like pattern. So, as a last, in the last minute of my talk, I went a little bit long, I would like to stress the fact that I'm not sure if comparing volume control or pressure control is a very important question from a clinical standpoint. Certainly, the principle on which these ventilatory modes work is very, very different, but I think it is important to recall that, first of all, there is no difference in the pressure that the patient will receive, whether we are on pressure control mode or volume control mode. the elastic recoil pressure of the plateau pressure will only depend from the compliance of the respiratory system and the tidal volume. So for the same patient, for the same tidal volume, the plateau pressure will be exactly the same no matter whether we are working in volume or pressure-controlled ventilation. I think I'll stop it here for the sake of time. And so I will just say that volume-controlled ventilation and pressure-controlled ventilation have very different working principles, but basically we can achieve the very same results no matter whether we use volume or pressure control modes. And I think that the hybrid modes such as pressure-regulated volume control, and I did not have time during my talk, but it's something you will definitely see during the hands-on sessions, share the main advantages of both. So a constant tidal volume, which is the key feature of volume control ventilation, and the presence of a decelerated flow. I thank you very much for your attention.
Thank you so much for this great talk. Any questions from the floor? Could you just comment a little bit about the flow? You didn't have enough time to do that, between the volume constant flow and pressure decelerating flow.
Yeah.
It's possible to use a volume control with decelerating flow?
Yeah, that's also another option. So the presence of decelerated flow has some putative advantages, mainly the fact that the decelerated flow is normally associated with a better CO2 removal, because different regions with different time constants have time to be ventilated. Another option, I'm not sure if it's an hybrid mode, but it is possible on some ventilators to use a decelerated flow while on volume control ventilation. I think it's a very interesting aspect. The only drawback is that if you want to do classical mechanical properties measurement, you have to go back to square flow. But besides that, I think it's very nice to have this option. So, thank you, Claude.
Okay. Yes, please.
But you have to, if you do decelerated flow, then you have to prolong the inspiratory time, right, to reach the tidal volume that you want.
Well, not necessarily, because you will have, as you see here, the areas of these two waveforms are the same. So you just have to achieve a higher peak inspiratory flow at the beginning, and then so the time, let's say, you lose here, you gain it here. So, thank you so much.